Sorry about that. Dear colleagues, dear clinical nutrition healthcare professionals, ladies and gentlemen, I am Rocco Barazzoni from Trieste, Italy. It is my distinct pleasure to welcome you to the joint session at the 2020 Virtual ESPEN Congress, organized by Medical Nutrition Industry, Optimal Nutrition Care for All Initiative, and ESPEN, entitled Living Healthier Lives During Cancer Treatment with Optimal Nutrition Care. We are all aware that cancer is an ongoing huge challenge for healthcare professionals, even in the time of pandemics. I would say all the more during pandemics, because unfortunately cancer patients are prone to more negative outcomes and complications if they are affected by COVID. So that's really a hot topic. Despite many improvements in recent years, cancer remains a major cause of death worldwide and in Europe. And importantly, a major cause of malnutrition with an important negative impact on patient quality of life, treatment options, and outcomes. But we have also to acknowledge, unfortunately, that the huge negative impact of malnutrition on the lives of cancer patients is substantially underestimated outside of the clinical nutrition community. This is all the more frustrating since we know that optimizing nutrition and medical nutrition can reduce the malnutrition burden with strong clinical benefits. The European Commission has recently acknowledged the need to address more effectively the cancer priority. It has launched the Europe's Beating Cancer Plan aimed at reducing, and I quote, the cancer burden for patients, families, and health systems. The inclusion of the major negative impact of malnutrition in this picture would be extremely important. Unfortunately, this goal is not yet achieved, or at least not completely achieved. Coming to the format and goals of the session, ESPEN is a multi-professional society, and we are fully convinced of the value of integrating multi-professional and also multidisciplinary skills to optimize nutrition treatment, and also of the importance of collaborating and getting the best inputs from patients. For this reason, we are from the beginning a part of the Optimal Nutrition Care for All initiative, where many partners and stakeholders are joining efforts to enhance awareness of malnutrition, also at political level. We directly collaborate with societies and organizations represented here. I'm very happy to mention very quickly that we recently signed a protocol to joint initiatives with EFAD, represented by the other moderator of the session, Professor Annemiek van Gimpel. So for all these reasons, I'm very happy that the session has been organized to discuss the importance of malnutrition for cancer treatment and outcomes. The goal is indeed to emphasize the importance of cooperation to tackle cancer-related malnutrition and to directly address and influence the EU cancer agenda. So with this, I'm happy to pass the virtual microphone to Professor van Gimpel.
Thank you, Rocco, for this great introduction. It's a great honor for me and for EFAD to welcome you as a sidekick of Rocco to this important session. EFAD is the leading voice of European dietitians, and we are representing over 35,000 dietitians and over 6,000 dietetic students in Europe. Last week, EFAD signed an agreement of collaboration with ESPEN, an important activity and a great achievement of our both teams. An activity in the collaboration of that assignment is that dietitians represent EFAD in the future guidelines, in which the dietitians will help to strengthen the knowledge transfer process, bringing nutrition science to practice. Since cancer patients are very prone to become malnourished already when cancer is diagnosed, and even further during the cancer treatment, dietitians have a key role in helping the patient to maintain or improve their nutritional status by providing person-centered and evidence-based dietetic counseling. And that all is taking place in a multidisciplinary setting. This session, we have 4 excellent speakers. I will now shortly announce. Maurizio Muscaritoli, ESPEN coordinator on oncology practical guidelines. He is announcing the ESPEN short guideline on oncology. Followed by Jacqueline Daly. She's from the European Cancer Patient Coalition, board member, and she will share her perspectives on the nutritional needs and concerns of patients with cancer. Then Marianne van der Schuren, co-author of the ESPEN Oncology Guidelines and fellow of EFAD, and she will show the important role dietitians have in implementing the guidelines. And last but not least, Frank de Man, he is Executive Director of ENHA, and he is announcing the call for action for EU Beating Cancer Plan. So Maurizio, the floor is yours.
Good morning, everybody. My name is Maurizio Muscaritoli. I am Professor of Internal Medicine at Sapienza University in Rome, Italy, and I am the ESPEN coordinator for the Oncology Practical Guideline. Let me first thank ESPEN, ONCA, and MNI for the kind invitation to join this session today. Some years ago, we performed together with ECPC a survey in cancer patients and survivors. The survey clearly indicated that patients and physicians have significantly different perspectives on the nutritional aspects of cancer and its therapy. Nearly all respondents, in fact, recognized the importance of adequate nutrition during therapy, and while the majority of respondents had experienced feeding problems during cancer therapy, more than 50% of them reported that their physician had not asked them anything about feeding issues. So this was another evidence of how nutritional and metabolic issues remain an unmet need for most cancer patients. In 2017, ESPEN published the ESPEN Guidelines on Nutrition in Cancer Patients, which were coordinated by Jan Arends. This was a challenging and exciting experience I shared with a number of esteemed colleagues and good friends. As you can see, this paper has a lot of citations, and I can tell you that the number of citations is going steadily up every day. Now, I will introduce the practical guidelines on clinical nutrition in cancer, which consist of 43 recommendations and which is based on the ESPEN guidelines on nutrition in cancer patients, which were coordinated by Jan Arends. The original guidelines were shortened by restricting the commentaries to the gathered evidence and literature on which recommendations are based on, but recommendations were not changed, and presentation of the content was transformed into a graphical presentation consisting of decision-making flow charts, which I will go to briefly introduce to you. So this is the main flow chart. You see on the top, clinical nutrition in cancer, and we have on one side the general concepts of treatment relevant to all cancer patients, and on the other side, the interventions relevant to specific patient categories. So not only this is the main flow chart, but in the digital version of these guidelines, this will represent a navigation menu. In fact, you can go into the specific sub-chapters just clicking on the box, on one of these boxes on the screen. Among the general concepts of treatment relevant to all cancer patients, of course, of major relevance, we found screening and assessment and energy and substrate requirements. And you know how the attention is focused on abnormal screening and weight loss. According to the presence or absence of weight loss, the user will be directed on one side or another. Again, with general concepts of treatment relevant to all cancer patients, nutrition intervention on one side, and of course on the other side, exercise. Nutritional interventions are divided into oral nutrition and medical nutrition. Of course, we recommend that nutritional needs are met by oral nutrition. If not, or nutritional needs may be met by the use of medical nutrition, either enteral or parenteral nutrition, if oral nutrition remains inadequate despite nutritional interventions such as counseling or oral nutritional supplements. And the focus is put also on exercise, which represent a main anabolic stimulus, which may facilitate the incorporation of nutrients within muscle. How about the intervention relevant to specific patient categories? In the field of medical oncology, for example, the setting of curative or palliative anti-cancer drug treatment, or the setting of high-dose chemotherapy and hematopoietic stem cells transplantation with different aspects and different recommendation for nutritional therapy, also for agents with insufficient proof of effectiveness on one side, and on the other side, exercise and nutritional therapy, and again, agents with insufficient proof of effectiveness as indicated by the experts. Again, interventions relevant to specific patient categories. On one side, cancer survivors, those patients who are after the disease, and for whom lifestyle recommendations are present, of course, healthy lifestyle, exercise, and on the other side, patients who find themselves in the palliative situation where nutritional therapy or hydration should be delivered according to the patient's conditions, patients and family expectations. And of course, we recommend that in the palliative situation, both nutritional therapy and hydration are discussed either with the patient or with the family and caregivers. So how do we plan to implement diffusion of these guidelines? This will be done through different strategies. First of all, a paper will appear in Clinical Nutrition in a few weeks containing the shortened version of the guideline. Then an app for Android and Mac iOS will be created. A web-based version will be soon available on the ESPEN website. We also plan to create a patient version in collaboration with patients' organizations, and the translation into different languages will be possible upon request, and it is strongly encouraged by ESPEN. So, I thank you very much for your attention.
Hello, my name is Jacqueline Deddy and I'm with the European Cancer Patient Coalition, and I would like to thank EPSON for giving me the opportunity to talk with you today. A little bit about ECPC. ECPC is the largest cancer patient umbrella organisation in Europe. We have over 450 members in 48 countries, including EU member states. We're the voice of cancer patient carers and survivors since 2003. ECPC advocates for patients to be acknowledged as equal partners and co-creators of their own health. Working towards a Europe of equality, access to the best treatment and care available throughout their lives. Nutrition and cancer care is a vital component in a patient's treatment and recovery. Adequate nutrition can help the patient better cope with their illness. Unfortunately, nutrition is often overlooked in cancer care, leaving patients, their families and carers without proper information on nutrition and unsure as to what to ask their doctors in regards to their individual nutritional needs. Poor nutrition can often be a side effect of cancer treatment and recovery. Cancer treatment can change the way food tastes. Often, patients can experience a metallic taste in their mouth. Depending on the cancer, the patient may experience a change as in the way that their body absorbs nutrients. Feelings of nausea coupled with diarrhea and/or vomiting can dramatically change the patient's weight, leading to malnutrition. Nutritional intake varies from person to person, and the patient's individual dietary needs need to be taken into consideration, as well as the treatment the patient is receiving. Different drugs can have different side effects, such as nausea, diarrhea, and pain. Any supplements the patient is taking. Some vitamins and herbal supplements can interfere with a person's treatment. The types of cancer. Some cancers, such as head and neck, can affect the person's ability to get adequate amount of nutrients. This can lead to malnutrition and cancer anorexia. Other conditions the patient may have. A person may be on a special diet due to another condition, for example, a heart condition. And I'd like to share with you a story of Frank, a patient who used our centre here in Ireland. Frank had a bowel cancer diagnosis, but 2 years beforehand had had a heart attack. Now, after his heart attack, Frank worked very hard to lose all his excess weight. He stopped smoking, he adopted a very healthy diet and was taking lots of exercise. Once he started the chemotherapy for his cancer, he started to lose weight very, very fast. And when he spoke in the hospital and, looked for some help as to what he should be doing, he was told that his calorie intake was very, very important. So he was to stop using milk in his tea and coffee. He should use full-fat cream. He should eat as many sticky buns and sweets as he wanted. That the important thing was to get his calorie count up. Now, of course, this wasn't the soundest information that he could have gotten, because his heart still needed to be looked after. We need to ensure that patients are looked at as a whole, not just as their cancer. Their whole health is important. So proper dietary nutrition is very, very important. The nutritional needs for head and neck cancers. Head and neck cancer are the 6th most common types of cancer in Europe, with more than 150,000 new patients diagnosed every year. Yet it is often diagnosed at a later stage. Head and neck patients are often at a higher risk of malnutrition due to the nature of their cancer. It can lead to patients with difficulty in chewing, swallowing, and other long-term side effects. The matter has been addressed in a booklet called Making Meals Make Sense, a cookbook and guide for people following head and neck cancer treatment. It was created by survivors of head and neck cancer, and it can be accessed on ecpc.org. Robert Precio is a head and neck cancer survivor, and he was part of ECPC's Make Sense campaign. And this is what he had to say about his experience with head and neck cancer. Adapting to eating was a gradual process for me due to the impact of my treatment, as I experienced pain and sensitivity in my teeth, gums, and tongue. While I used to find it embarrassing to eat in public, over time, I have strengthened my jaw muscles, and as things began to return to normal, I was able to start eating and talking as I had before. Children are also at a high-risk category, with the added need of nutrition to grow and maintain a healthy immune system. Depending on age, it may be difficult for a child to express their needs. And following treatment, nutrition has to be closely monitored with school lunches, etc. Some of the things that we should be asking when we go to see our doctor. First, we should request regular nutritional screening, dietary counselling, and psycho-oncological support as part of our medical care. We should ask, what is my current weight? And is it important for me to maintain my weight during treatment? How can I improve my appetite and nutrition during treatment? What do you recommend I eat during treatment? Are there any foods I should avoid? What are my options if my normal dietary nutritional intake is insufficient? And should I be taking vitamins or antioxidants during treatment? It is important to remember, as a patient-appropriate nutritional care and information is your right during and after treatment. Patients should undergo regular nutritional screening and counselling and be given the information they need to be more aware of their own nutritional needs during and after treatment. Patients' individual needs should be assessed and listened to, and various cancer types should be taken into account. Patients should be involved in the development of clinical guidelines and recognised as an important factor in their own care. So what I'd like you to take away today, don't be afraid to seek help. Knowledge is power.
Good morning, everybody. My name is Marianne van der Schuren. I'm a dietitian by background, and I have been a co-author of the ESPEN-Oncology Guidelines. The oncology guidelines were published in 2017 under supervision by Jan Arends, and there's both a scientific paper as an expert group recommendation for action. The guidelines, as just summarized, contain many practical recommendations on nutritional screening, nutritional assessment, body composition measurements, diagnosis of malnutrition, and they also give guidance to an individualized dietary advice. For example, by proposing more than 1 gram of protein per kilo and 25 to 30 kilocalories per kilo. However, these guidelines do not contain recommendations to translate this amount of protein or these kilocalories into food. And they also do not tell us how we can motivate the patient to meet requirements. So these practical translations are lacking. This is important because a patient does not eat kilocalories or protein. He eats food, like bread, protein-rich food, vegetables, and fruits. I want to illustrate the importance of eating and eating enough on the ESMO guidelines that were the ESMO systematic review that was published in 2018. We reviewed dietary intake studies and did a meta-analysis of the evidence of nutritional intervention to support patients with cancer. We did not publish the data that I'm showing you now on the screen, but it's important to understand what's happening. You look at randomized clinical trials. Patients were given a dietary advice or oral nutritional supplements and advised to increase their intakes. And the recommended intake is in the blue thick line. What you see in the 3 studies depicted here is that even in the intervention group patients, most of the patients never reached their dietary energy goals. And if we're looking at protein intake, you see the same thing. Most of the patients never reached their dietary protein goals, not even in the patients that were in the intervention group in these studies. So what we saw in the meta-analysis, that dietary counseling or nutritional supplements did improve weight, but not statistically significant, can partly be explained by the fact that the patients never met their dietary requirements. A newer study, the EFAD trial from 2019, nicely illustrates that meeting dietary requirements can be very effective. You see the red lines and the blue lines. The red lines are the patients who receive their dietary requirements, hospitalized patients, versus the blue lines, the control patients, and the ones who received their optimal diet, they had less adverse outcomes and they had a better survival. This underlines the importance of a good dietary advice that enables patients to reach their dietary intakes. So this is where the dietitian comes in place. If a patient has cancer and he is expected to live for at least 3 months, he is first screened for nutrition risk and a diagnosis on nutritional status is made. If the patient is found to be at risk, a dietitian comes in and performs a comprehensive dietary assessment. This consists of nutritional status, metabolic status, functional status, symptoms impacting on nutrition intake, GI function, pain, dyspnea, psychological distress, medication, and tumor status. Based on this comprehensive nutritional assessment, the dietitians start a tailored intervention which comprises all of these points of attention. If a patient is not at risk, he should be rescreened at regular intervals. And if a patient has a relatively short life expectancy but is experiencing eating-related distress, the dietitian can help to relieve this distress by giving nutritional advice on, for example, cachexia, treat symptoms, and offer psychological support. The dietitian takes into account symptoms like pain, nausea, vomiting, the mood of a patient, his therapy and the expected side effects of the therapy, recent changes in weight, and the tumor stage. She translates all this information into food. For example, into foods rich in protein. Also, she can advise on taking extra supplementation, vitamins, minerals, or even enteral or parenteral nutrition, oral nutritional supplements. And she will take into account the treatment and the side effects coming along with the treatments, such as mucositis, vomiting, diarrhea, or pain. And I'm very happy that ESPEN and EFAD have decided to join forces, because dietitians are the experts to translate science into practice, science into a practical advice for patients. And also, I think every guideline should involve at least a dietitian to perform these tasks. So I hope that in future ESPEN guidelines, always an EFAD member will be involved. Also, by joining forces, I think the guidelines will have a larger impact, because dietitians are involved in delivering and optimizing nutritional care of cancer patients in the wards, at home, and they also play a role in education of medical doctors and nurses. So I think that the collaboration of the two scientific, both ESPEN and EFAD, will help to improve the effectiveness of dietary interventions in patients suffering from cancer, and to improve the patient-centered outcomes. I think that I hope that implementation of guidelines will go to a higher level, and this will result in optimal nutritional care for all. I thank you very much for your attention, and I wish you a good virtual ESPEN. Thank you very much.
Frank de Maan, Executive Director of the European Nutrition for Health Alliance. I'm happy to invite you for our digital conference called EU for Nutrition, live broadcasted from Amsterdam, Brussels and Madrid. We organized this digital event together with our members and partners like the European Patient Forum and the European Coalition for Cancer Patients to secure nutritional care being embedded and included in future European health policies, research programs, as well as national health policies. Malnutrition and undernutrition affect more than 30 million European citizens per year. Main risk groups are older people and people with disease-related issues, with chronic diseases. And as a result, malnutrition and undernutrition affect healthcare budgets substantially. Scientific evidence proves that optimal nutritional care decreases the risk of mortality, decreases comorbidity, and optimizes quality of care for chronic patients and older people. Currently, nutritional care is not included in many of the curricula of medical schools in Europe, and that has to change. And this is strongly supported, this change is strongly supported by this European Medical Student Association, as well as some key partners and members of the European Nutrition for Health Alliance like ESPEN, EFAD, and the European Geriatricians of EU-GMS. Members of the European Parliament that support our activities will speak on general EU policy issues and help us and advise us how to make this step in the future to integrate nutritional care in EU health programs. But they also will focus on specific topics like COVID and cancer. It's therefore that we would like to invite you for this joint event on the 1st of October. Join our workshops on the EU Beating Cancer Plan and nutritional care, another workshop on learnings from COVID, and the third one about how to implement nutritional care in European and health policies. So may I ask you to join, register for free, and join our European-wide campaign to improve nutritional care for European citizens. Thank you.
Good morning, good afternoon, good evening, ladies and gentlemen. My name is Fernando Mateus and I'm the president of the YMENI. It is a great pleasure to be part of this important congress, especially this session in partnership with ESPEN and with ONCA. The choice of this session, or the title of this session, couldn't be closest to my heart. I deeply believe that healthcare professionals, care institutions, patient associations, policymakers in the industry have a big role to play in improving the quality of life of cancer patients. With that in mind, the YMENI have commissioned to an independent agent an extensive literature review about malnutrition in cancer patients. The results of that review can now be found in our website. The conclusions confirms that malnutrition is highly prevalent amongst cancer patients, reaching numbers as high as 50% in gastrointestinal cancer, more than 45% in head and neck cancer patients, and above 40% in lung cancer patients. And it also confirms that this malnutrition is often underdiagnosed and therefore undertreated, leading to an increase in mortality. We can all do better here. And I'm sure that if we all work together, we can improve cancer treatment pathways. And we can make sure that nutrition care becomes an integral part of the cancer treatment. Moving now to the YMENI grant, I would first like to thank the long-lasting collaboration with ESPEN since we started with the YMENI grant back in 2008. 2021, it's not going to be different, and we will have the YMENI grant. The criteria are already available in our website. I encourage you all to participate and to disseminate this information. For this year, we had 15 very high quality submissions, which didn't make our life easy when we had to choose the winner. Luckily, we do have the valuable collaboration of an ESPEN representative. All the 15 submissions can be found at the MNI website, and also very kindly ONCA have agreed to disseminate these best practices. And now I would like to announce the winner. I'm very happy, and it's with great pleasure that I announce that the winner of the MNI grant is Carmen Gomez-Candela and her team for the outstanding work they've done in the validation of the GLIM criteria in a Spanish hospital. Carmen, please receive our virtual round of applause and the MNI grant check of €30,000 that for sure will help you and your team carrying on the outstanding work. Thank you so much for your attention. Wishing you a great Congress.
Good morning, ladies and gentlemen. It's a pleasure for me to stay here on behalf of our care team and our research group, and also as part of the Spanish Society of Clinical Nutrition that we represent, SEMPE. We are really very happy and grateful to have received this grant to carry out this important but complex project. My name is Carmen Gomez-Candela. I am the head of Clinical Nutrition Department of Hospital La Paz. This is my hospital, and the director of the Nutrition and Functional Food Research Group. This is our institute, and professor of the University Autónoma of Madrid. The title of the study is the identification of the most effective and fastest tool for nutritional diagnosis in hospitalized patients. As you know, there is controversy over what is the best way to screen and diagnose disease-related malnutrition. This is a very complex clinical condition with inflammation, chronicity, and severity that are very difficult to measure. We don't know what is the more accurate system, the less time consuming, and what is the gold standard. This project is focused on discerning if there is concordance among different validated diagnostic strategies used in clinical practice and the new line criteria. An ineffective diagnosis will lead to a better and more individualized treatment and codification. The main objective is to estimate the degree of concordance of nutritional diagnosis among the criteria proposed by the Global Leadership Initiative Malnutrition Line, the Global Subjective Assessment, and the International Classification of Diseases, 10th edition, based on the Nutritional Status Assessment. Also, as secondary objectives, we analyze our screening method, we estimate which is the best way to measure muscle mass, and some biochemical parameters. As you know, subjective global assessment take into consideration changes in weight, dietary intake, gastrointestinal symptoms, functional capacity, nutritional requirements, and some aspect of basic clinical examination. In our clinical practice, in the nutritional status assessment also, we include anthropometry, biochemistry, and dynamometry. And after this process, we have to perform a diagnosis according to the International Statistical Classification of Diseases by the World Health Organization, 10th revision, and to put a diagnosis in this part. So we need an expert staff, and it takes about 1 hour per patient. But the recent publication of the GLIME criteria propose a probably short and easy to use criteria for the diagnosis of malnutrition. It's a consensus report made for different clinical nutrition international societies, and after the risk screening, we had to make an assessment of phenotypic criteria as weight, body mass index, muscle mass, and aspect about the food intake, absorption, or disease characteristics. After diagnosis, we had to grade the severity of the illness. But in practice, we are not sure it's really so easy to perform. As secondary objective, we will use our screening method, CONUT. It's an automatic screening system based on measuring 3 biochemical parameters. We use it in our hospital from 2010. And also, recently in this paper, we have shown that also offers an advantage of being a prognostic factor of complications, rate of re-entry in the hospital, and mortality. And about the secondary objectives, it's very important to try to study which is the best way to measure muscle mass in clinical practice, in the routine, because it's very time consuming. Anthropometry, echography, clinical electrical bioimpedance, dynamometry, and we are going to work very hard in this way. This is a cross-sectional observational study. We will study around 1,000 patients admitted to our clinical nutrition department. The total period of the study will be about 1-2 years. The whole multidisciplinary clinical nutrition team is involved in this study with the approval of our ethical committee, and we have the very important collaboration on a company, expert in statistical analysis, this is the name, that is in Galicia, in the north of Spain. Now all activities are scheduled and we have almost all devices prepared. With a criteria GLIM has been published recently, but there is not enough feedback studies about the reliability and concordance with other clinical practice strategies. But if concordance is identified, GLIM criteria along with the best measures and parameters will be implemented in our daily hospital practice in the future, because really we need an easy, conscious, reproducible, and non-excessive time-consuming methodology to diagnose malnutrition in hospital. Of course, we will publish the scientific results that could influence national nutrition policy and probably are transferable to other countries as the malnutrition diagnostic methodologies are used in international. And that's all. Thank you very much for choosing us, and be sure that we will do our best. Thank you very much.
So, but again, I really think that this is a meaningful initiative. I want to thank again Dr. Mateus and MNI for this ongoing collaboration. It is a very stimulating initiative, a grant that can help boost national networks, national ideas to increase the implementation of nutritional treatment and malnutrition care. And I also congratulate the winners, because we are all very much convinced that the GLIM initiative, the criteria for diagnosis of malnutrition that are shared with a consensus process with many stakeholders around the world, and also fully supported in Europe by ESPEN and EFAD, it's a very important topic for such an initiative. So thank you both. Thank you for the ongoing grant initiative. And with this, I leave the moderation to Annemiek van Gimpel for closing remark. Thank you for your attention, and please, Annemiek.
Thank you all for your attention at this important session. I want to close with what Jacqueline Daly said. Patients should ask help, and knowledge is power. And if we work together in ESPEN, MNI, ONCA, and EFAD, I think cancer patients could be treated better, having a better quality of life, and the recovery should be going faster. So thank you all, and I hope we meet you again at the 1st of October in the EU Nutrition Live, which Frank de Man introduced. Thank you, and have a good conference.
Thank you.